hello again. For those of you who sat through my first presentation, I'm Connor Bounds, and I'm going to be talking about hypoventilation syndromes today. Just as kind of a disclaimer, again, everything talked about here is not a reflection of my employers. They're all my opinions, and again, I have no financial investments in any of this stuff. However, in the last 15 minutes, if you know anybody who wants to invest in me financially, Jeff can get you my contact information.
That's right.
So, a little bit about the talk of today. So our objectives, we're going to define what a hypoventilation syndrome is. We're going to describe the various causes of these hypoventilation syndromes, and then we are going to outline a general treatment plan for these syndromes. So really, when we talk about hypoventilation, we are not talking about just a decreased respiratory rate. We are actually discussing inadequate gas exchange at the alveolar level, which is producing increased carbon dioxide levels in the blood. So really a better term for hypoventilation in this case would be alveolar hyperventilation. We're not talking about rate, we're talking about the actual cellular gas exchange here. So, talk a little bit about the causes of these syndromes. The etiology, the causes for hypoventilation are numerous. These are just a few of them. You can have your neuromuscular diseases, like your Guillain-Barré syndromes. You can have central nervous system disorders that can produce hypoventilation, obesity, trauma, stroke, drug use, and chronic respiratory conditions like congestive heart failure. So let's talk a little bit about the epidemiology of these. So in the case of our hemorrhagic stroke, there are 24.6 cases per 100,000 person years. Let's talk about this person years real quick. Basically, a person year is, in these studies, if you take the number of people in the study and multiply it by how long the study lasts for, that's how you get your person year. So, example, if you took 1,000 people, enrolled them in a study in which they were followed for 1 year, then that would be 1,000 person years. So if you had 5 people in that study, then you would have an incidence of 5.0 per 1,000 person years. So anyway, kind of want to, it can be confusing pretty quickly with this stuff, but it's just a way of describing how often things occur. So these hemorrhagic strokes, 24.6 per 100,000 person years. Opioid overdoses in the U.S. These are non-fatal overdoses, by the way. This is just an overdose in general, both fatal and non-fatal. 0.04 to 46.6 per 100,000 person years. That data is actually from, I believe, 2016. I'm interested to see how the 2017-2018 data compares. They say that 2018 incidence of opioid overdose is down, but I'm waiting for those numbers to come out. COPD in the U.S. alone, in the U.S. alone, there's 5.8 million cases of COPD. CHF worldwide, depending on which population, which country you're looking at, it's anywhere between 0.2 to 37% of the population, depending upon which country you're looking at. So let's talk a little bit about how we actually get these various conditions. So the pathophysiology, before we can understand abnormal, we need to go back and discuss normal. So what is our normal control of ventilation here? Without going too terribly far in depth into it, we monitor our arterial blood supply. And we monitor our carbon dioxide and oxygen levels. So through two main mechanisms, we have our carotid body over here, which is a small outpouching of nervous tissue there at the junction of the internal and external carotid arteries. And then down here we have the aortic body, which is the same thing. It's kind of an outpouching of tissue there in the aortic arch. So these are what they call peripheral chemoreceptors. Basically anything that's not directly located in the brain is considered a peripheral chemoreceptor, and those are controlled by both increased carbon dioxide levels and, to an extent, decreased oxygen. but primarily our main driver is hypoxia, and it's that really is through the carbon dioxide. So how does our central nervous system monitor our ventilatory status? Well, over here we have our arterial blood, and let's just say that this whole reaction over here is taking place in a red blood cell. Our red blood cell is basically a giant bag of hemoglobin and a couple proteins and an enzyme. So the problem with monitoring blood in the central nervous system is that we are going to monitor our pH through hydrogen ion concentration, right? Well, the problem is this blood-brain barrier is not responsive to CO2. So we have to find a way to say, hey, what's our CO2 level in the arterial blood? How do we monitor it in the central nervous system, specifically through the CSF? So what we have is a reaction over here by which we take our carbon dioxide and water. It's picked up, through the red blood cell, and it becomes carbonic acid, and then we have a little enzyme over here by the name of carbonic anhydrase that breaks it down into bicarbonate and a free hydrogen ion, and that little guy right there can move across the blood-brain barrier and get into the CSF, and that is how the central nervous system actually monitors our carbon dioxide level. So it's not monitoring it directly, it's monitoring it in kind of a roundabout way. So we'll go over this real quick and we'll talk about it more in trauma. Content check, what are the 3 findings that make up our Cushing's triad? And I'll give you guys a couple seconds to think about it. You don't necessarily have to type it in, you can if you want to, but we'll kind of move on. And you can see if your answers were correct, and that is bradycardia, slow and irregular breathing, and systolic hypertension. Let's say we'll come back with that. So opioids. The entire purpose of an opioid is to block pain sensation in the central nervous system. There's a problem with that. One of our main opioid receptors, the mu receptor, is also responsible for our ventilatory status. So when we have our opioid overdoses, that is why we also have our hypoventilation associated with that. And as you all know, the big hallmark for our opioid overdoses are our pinpoint pupils, which we should be looking for on our unresponsive patients as we are ruling out those causes of altered mental status. Obesity hypoventilation syndrome. This one became very near and dear to me when I went to the doctor last time and he told me that I needed to lose some weight. It's defined as hypercapnia, or a partial pressure of carbon dioxide of over 45 millimeters of mercury. Just kind of an aside, that partial pressure of CO2, that PCO2, actually correlates very well with the level of carbon dioxide on your end tidal. They're about equivalent. So an individual with obesity hypoventilation syndrome would have an end tidal of over 45. Anyway. They have to have an obesity diagnosis from their physician, and they have to have a BMI of over 30 kilos per square meter. And it literally is excess tissue that prevents them from ventilating themselves adequately. And as a result of poor ventilation, they have poor gas exchange, hence the increase in partial pressures. The doctor says he found out why I snore so loudly. It's obstructive sleep apnea. That's English for internet fat. I like the way the doctor said it better. So yeah. COPD, asthma, and emphysema. So this is kind of a mixed bag of causes, but the end result is all the same. It's trapping of air in the alveoli in the lungs. And like I said, there's multiple mechanisms by which this works. So we're going to kind of break down the COPD emphysema into one category and the asthma into a different one. So our emphysema, we often find this with people who are smokers, and it's kind of a multifactorial reason why they have hypoventilation. If we're using our alveolar hypoventilation definition, they have just chronic obstruction. These individuals often will have infection associated with it. One of the big things is, and the reason why cigarette smoking causes such a high incidence of emphysema, is nicotine will actually paralyze the cilia in the lungs or in the upper airway. So they can cough all they want, but there's no way that mucus is getting out of there, and they basically develop these mucus plugs, and it will produce anywhere between 50 to 80% destruction of the alveoli. So lesson from this, EMS friends, stop smoking. It will also take care of your hypertension. You won't have to worry about heart failure. See? So asthma. This is an immune reaction. It's immune-mediated bronchospasm that results in the body basically overreacting to some kind of a foreign substance. You know, pet dander, cigarette smoke, tree pollen, all that fun stuff. It's mediated by the IgE antibody and leukotrienes, and so what you'll often find is that people with asthma, they won't have anything to really mess with this other than maybe occasionally being on allergy shots, and you can find that during your HPI and physical of the patient. But you will often find people on these leukotriene inhibitors, and they are basically another immune component that are responsible for producing the vasoconstriction. They recruit a bunch of immune cells to come in there and try to fight off that allergen. So one of the big ones that you'll find, Montelukast is one of those leukotriene inhibitors. So you see that on a patient's, med record while you're talking with them, or they tell you what they're on. Okay, do you have asthma? Do you have, something like that? So CHF, we talked about that one earlier. If you haven't had a chance, you can go back and watch another video, but it is your decreased cardiac output. As we discussed earlier, there are both peripheral and pulmonary effects. We'll show a little picture here of this. So again, here's your pulmonary edema. As you've got your poor cardiac output, you are not able to move blood from the pulmonary circulation, and so you get that excess fluid, gets pushed out into the alveoli, causing your wet, nasty lung sounds and respiratory distress. There is a picture of your pitting pulmonary edema over there. Squeeze that leg, and it almost looks like a potato right there. But anyway, sorry. So there's your peripheral edema from your right-sided heart failure as well. So the history and physical on these patients. The physical exam on them, again, is focused on your ABCs. You are going to try to improve their ventilation and their oxygenation. You can't always determine, especially when you kind of get out into the weeds on some of this stuff, there's a whole laundry list of other causes out there for these hypoventilation syndromes. People with hypothyroidism, overall they've just got the nasty, lethargic, can't breathe, can't do much of anything issue. You may have a pretty good idea, and that could be in your working diagnoses for what's causing it, but I'm sorry, in the field we're not going to fix hypothyroidism, but we can support their ABCs. So if you don't know what the cause is, fall back on your airway, breathing, and circulation. Make sure that you've got good, equal chest rise and fall, that you've got good lung sounds, that you're moving air appropriately. So history, again, we look into our signs and symptoms, our allergies, our medications, and again, this is a big one. Like we talked about earlier with the leukotriene inhibitors. As you're going through, I'll ask this question: how many of you have ever gone on a call, and I'm going to be shocked that this has ever happened to anyone, and you're talking with your patient, and you ask, "Do you have any medical history?" And they say, "No, I'm fine. I just called today because I have a cough." Okay. "Do you take any medicines?" "Yes." And they pull out their wallet, and it falls out like, the pictures of the grandkids, and they've got 700 medications that they're on. You're like, "You're on Ditch, and you got Bertilium on this list? How long have you had medical problems?" Anyway, the older people will get that joke. The younger guys might not. Anyway. So past medical history, the last time they had food or drink, and then what led to the 911 call. "Hey, did your friend go into the bathroom and you haven't seen him for for 15 minutes and now he's got a needle sticking out of his arm. Oh, were you outside mowing the yard and you know that you're allergic to trees and now you're having trouble breathing? Anyway. And again, your OPQRST, your onset, what was going on when this started, similar to the E in the sample history. Anything that makes it better or worse. You have any pain, and if so, what's it like? Does the pain move anywhere? That's if it's applicable. Severity of the pain, if applicable. So, like I said, let's go back and kind of talk about management of the hypoventilating patient. So, we need to discuss our differentials here. So, as I said earlier, not everything is going to be identifiable in the pre-hospital realm. There's going to be times where literally the only thing that you are working on these patients is maintaining an open airway and making sure that their vital signs are good and they are exchanging gas. Management of most of it remains for the same of EMS. Hey, if you've got a specific cause like asthma, we've got stuff we can do to treat that. But like with the Guillain-Barré syndrome, we can't fix that other than making sure that they're maintaining an open airway and ventilating well. So again, treatment can be based upon the underlying cause of the hypoventilation if it's known. If you're not sure what's happening, fall back on your ABCs. So our ABCs, there's a non-patent airway, we open it. Head tilt, chin lift if it's not traumatic, do the jaw thrust if it is. Look for an indication of an NPA or an OPA. Do they have snoring respirations? Get that tongue out of the way. Do they have a gag reflex and they don't have a head injury? Lubricate and gently insert an NPA. I don't want to say that I want to slam anything into the nostril. If they're not breathing, give them bag valve mask ventilations. Are they breathing on their own, but they've got a poor pulse oximetry? Give them supplemental oxygen by whatever manner you see fit. Is there major bleeding? Control it. In the scheme of things, if you're unsure what's going on, work on these, and then begin while you're addressing these three things. You can begin thinking about, okay, what kind of medical history do we have here? What information are we gleaning from the scene? Do we have medications lying around? Do we have family on scene or neighbors that can help us with stuff? Nosy neighbors can be helpful sometimes, just as long as you don't violate HIPAA with all that stuff. So again, if you know the specific cause of hypoventilation, you may treat it if applicable. So in our stroke and trauma, we need to rule out our causes of altered mental status, and we do that using our AEIOU TIPS mnemonic. That is alcohol, epilepsy, insulin. Are they altered and not breathing because they have no blood sugar, literally, to breathe anymore? So check blood sugar. Is it an overdose? Check your pupil signs for your narcotics. Check an EKG if you're worried about something like a TCA overdose. Uremia. Do they have renal failure? Are they having issues with maintaining breathing because they've got excess ammonia in the brain, and that's what's going on with the renal failure? Toxins. It can be other things. Are you dealing with an individual who, around here in the farming communities, do you have an anhydrous ammonia overdose? So have they come in contact with something that's causing them not to breathe? Infection. Is it a little old lady or a little old guy who's septic and they just are running on empty and they're not breathing anymore because they're so sick? Is it psychosis? Could they be crazy and they're just having an issue with a psychiatric problem? That's possible as well. And then I just forgot the S. So if anybody remembers the S, sepsis. There's the sepsis. Thank you, gentlemen. So infection or sepsis, it could be either or. One of the big things, though, in these individuals is maintaining a mean arterial pressure greater than 65. You do want to make sure that they're still perfusing their brain, and we can titrate our fluids to that effect, and you can calculate the MAP by taking 1/3 of the systolic and adding 2 times the diastolic. A lot of the monitors now, I think Zoll will give you a MAP over in the parentheses next to your blood pressure, so that helps. If in this stroke or trauma patient, and depending on how big the bleed is in a stroke patient, you can have herniation. So, be watching for those signs like we talked about earlier of the Cushing's Triad. Are they breathing slowly and irregularly? Do they have hypertension? Consider mild hyperventilation if you think that those signs of cerebral herniation are present. Opioids, again, this is a specific cause. We look for the hallmark sign of the pinpoint pupils. Consider giving them 0.4 milligrams IV or IN naloxone up to 2 milligrams. Really, the big thing you don't want to do is to slam Narcan on an overdosing patient for a couple reasons. Number one, once you slam that Narcan, you run the risk of causing further airway issues, because vomiting is a huge problem with narcotics overdoses. Specifically, there is opioid-linked constipation. That's a constant problem for people who are chronically on opioids. Well, it's not just constipation. There's also some general stomach issues as well. So if you slam that Narcan, congratulations. Now you have someone who may be upset because you've taken their high away and they're fighting you, and now they're also puking everywhere. So you also might want to consider some Zofran. Again, following local protocols, but you can also kind of mix your Narcan and give a little Zofran chaser as well. It also keeps you from having to clean the truck too much when you're done. But also maintain that airway. While your partner is drawing up the Narcan, you can drop an NPA or an OPA and ventilate the patient. Again, all these things, you're falling back on managing your ABCs. So don't forget about keeping the airway open and ventilating the patient while you're taking care of the other things. Obesity, we talked about this with the obesity hyperventilation syndrome, where there's literally so much tissue that these individuals cannot breathe adequately. There is nothing really that we're going to be able to do for them. That is a chronic problem that they are going to have to work through with their physician. One of the big things, though, is put them in a position of comfort, set them up quite a bit so that any of the excess tissue is actually pulled kind of down and out away from the chest wall. That might be able to help them breathe a little better. If you have an unconscious patient and they are an obese individual, you may have to delegate a few people to solely manage the exterior equipment on the airway. And what I mean by that is, if you are having a difficult airway problem, you may have to have someone come over and all they do is perform a jaw thrust. And a second guy, or gal, all they do is make sure there's an adequate mask seal. And there's difficult airway algorithms and stuff that you can use for that as well, that's a topic for another time. So our pulmonary causes, how do we try to work on improving oxygenation here? Well, as we said earlier, COPD and emphysema, we are going to try to improve their oxygenation kind of in a stepwise fashion. The first thing you can do is start providing them with supplemental oxygen. These are the individuals who you will often find them being on supplemental oxygen at home, usually through nasal cannula, 2 liters, 4 liters per minute, whatever the case may be. As you're talking with these individuals and trying to find out why they've been having these issues, why they've called, you're going through your sample OPQRST, I don't know, I just haven't been feeling well, but I usually wear 2 liters in my nose, and the last couple days it's up at 4, and it's just not helping. Okay, well, we may need to jump up to something a little stronger, maybe try a downward breather. As we're listening to lung sounds, do they have some constriction going on? You can maybe try some albuterol. Cpap if they've got any kind of pulmonary edema going on there as well. And again, if local protocol allows for it, if it's not getting any better with your basic interventions, you can try something like an RSI or a DSI and actually intubate the patient. Now, asthma, this is a big one for us. We know, again, that it's an immune-mediated reaction, and our job in the case of asthma is to make sure that we but that we attempt to slow the body's reaction to a foreign substance. Because that immune reaction is what is actually causing our bronchoconstriction and causing our signs. So, let's talk about the drugs that we're going to give here. Our albuterol, that is actually a beta-1 in the heart and a beta-2 in the lungs agonist, and its job there is to increase the heart rate and the cardiac output. It's a positive inotrope through the beta-1 receptor in the heart. But our big thing, the main heavy hitter, is beta-2 agonism. That is going to be our bronchodilation there in the lungs. And then we also have our ipratropium. That one blocks the muscarinic receptors in our parasympathetics there in the bronchioles and causes some smooth muscle relaxation as well. Benadryl, allergic reaction cocktail. You know, you've got your Duoneb, you got your Benadryl, and your Solu-Medrol. But the Benadryl's diphenhydramine. We all love it. It's great for sleeping on long car rides too. But it's an antihistamine. Specifically, in this case, it blocks the binding of histamine from our immune system onto our blood vessels. Because what we have with true histamine, with true anaphylaxis, widespread vasodilation, their pressures are terrible, they look sick, it's a true medical emergency. So even though it stops some inflammation, and yeah, you can pop 12.5 milligrams of Benadryl to take care of your nose, we also need to stop the vasodilation and the anaphylaxis. We'll kind of chase a rabbit trail real quick for a second and discussing the hypoventilation associated with allergies and anaphylaxis. You know, when we're dealing with an allergic reaction, that's when we have our kind of slow onset. It's usually, you know, contained in the arms or the chest, and you've got your rash and your itchiness. You maybe have some runny nose, runny eyes, sneezing, stuff like that. Versus your anaphylaxis, which is your true medical emergency. It's rapid onset. You've got the vasodilation leading to hypotension. You've got airway compromise, possibly through all of the different secretions and stuff that are going on. Anyway, so yeah, just remember the difference between the slow onset and kind of generalized symptoms versus rapid onset, widespread symptoms when you're treating your asthma versus anaphylaxis. Solu-Medrol, this is your methylprednisolone, and it is it's an anti-inflammatory, specifically a steroid. It helps slow the inflammation associated with this. So it's good to kind of slow the recruitment of immune cells into the airway. However, because it's a steroid, it takes a while, anywhere from 2 to 6 hours before it actually starts to do any good for the patient, if you will. But it's still something that we can get on board for these asthmatic patients as well. And again, you know, you may go out on this asthma patient and you find that they're in severe respiratory distress and they're breathing 40 times a minute. You wouldn't think, this is a hypoventilation syndrome. They're breathing 40 times a minute. But it's important to remember that these cases are alveolar hypoventilation. You don't have good gas exchange at the alveoli. And so that's why asthma can be considered an alveolar hypoventilation syndrome. You're not getting the gas exchange that you need to maintain life. Last but not least, magnesium. Somewhat of a newer drug, depending on where you're working at. It is a bronchodilator. It's considered kind of a last-line bronchodilator in respiratory distress. It's not fully known how this one actually works. It's believed that it acts like a physiologic calcium channel blocker. It's basically, for all intents and purposes, in the airway, a calcium channel blocker. And it will help actually relax that smooth muscle in the airway, because you don't have the capability to bronchoconstrict when you've got the magnesium on board. Usually given as, actually, I think it's always given as a drip, and you have to monitor for side effects on that stuff. I think we'll talk about that in just a second. So, what could possibly go wrong when we are taking care of these patients? Like this, a nuclear power plant next to a spider farm. What could possibly go wrong? Those old crazy 1950s sci-fi movies where we get nuked by the Russians, and not only are we dealing with fallout, but we're dealing with 12-foot diameter spiders who want to eat everybody. So the side effects, CPAP and hypotension. We talked about this earlier in the CHF lecture. This is kind of a relative contraindication. You should remember that if a patient is hypotensive, systolic blood pressure less than 90, we do need to be concerned about CPAP. Now the reason why CPAP can create a problem in the hypotensive patient is because it actually increases your intrathoracic pressure. So, thank you, sir. So, yes, you may be helping move that fluid out of the alveoli, but you are also increasing the intrathoracic pressure, and as a result, you can be impeding blood flow back to the heart. So, it's a relative contraindication. Most places will tell you that if you have a patient who has a systolic blood pressure of less than 100, you should contact medical control before starting CPAP. And again, most places will tell you that systolic blood pressure less than 90 is an absolute contraindication for CPAP. Other complications, as I said earlier, as we fall back on our basic airway management of ABCs, if we're doing bag valve mask ventilations, we do need to be concerned about gastric distension. For the BLS provider, that is making sure that you have, and for the ALS provider too, making sure you have a good patent BLS airway. Use those NPAs, use those OPAs, get a good mask seal and all that, making sure that the stomach's not getting bigger as you're ventilating the patient. That doesn't look right. We should probably stop. For the ALS provider, you also can do a nasogastric tube to decompress that stomach if it's too far distended. Now, some of you may be saying, what about the Selleck maneuver? Some good old-fashioned cricoid pressure to prevent gastric distension. Myths in emergency medicine. Cricoid pressure, nothing more than nostalgia. From Emergency Medicine News, January 2019. This was a study done in Great Britain, and it enrolled something like 1,000 participants, and the rate of gastric distension and vomiting in the cricoid pressure was actually more than the individuals not receiving cricoid pressure. So this Dr. Spiegel has actually said, hey, we need to do some more studies in this arena. But just know that it's good for intubating, but it may not be as helpful in preventing gastric distension as we once thought. Nitroglycerin and hypotension, specifically in those CHF patients, remember that we might be able to improve their oxygenation if we put them on CPAP and vasodilate those vessels, but it does no good if they have no blood to move around because their blood pressure is 60 after we've given them nitroglycerin. So again, relative less than 90, don't give nitroglycerin. The old idea of giving nitro to the inferior STEMI patient also may hopefully be on the way out as well, but that's a topic for another time. Cannabis and albuterol. As more states are legalizing cannabis, this may actually be something that we begin to run into. There is an interaction between cannabinoids and albuterol, which is kind of counterintuitive, whereas the marijuana will actually worsen tachycardia in albuterol. And so what you can find is, hey, this patient has, is an asthmatic, and he's been smoking, and he's not feeling well, and now he's having respiratory distress, and I can, looking at bronchospasm based on my capnography, I think I'm going to hit him with some albuterol. Well, he's already hit himself with some cannabis, And so great, now you've got, you know, a relative, a patient that's relatively in shock because their heart rate's, you know, 140, and sorry, I mean, you really can't cardiovert that because it's not an electrical problem, it's an interaction between two different drugs, so something to be considered as well. So how do we enhance the outcomes in these patients? We have to remember that it is a team-based approach, and the positive outcomes start with you. EMS can consult with online medical control very early and ensure that these patients with hypoventilation syndromes are being taken to the most appropriate facility. That does not always mean the closest facility. Specifically, we should be looking for places that have critical care medicine on staff, as well as respiratory therapy as well. Consider aggressive airway management and CPAP early in some of these patients, specifically your congestive heart failure patients, to reduce the need for pre-hospital and emergency department evaluation. There are many services who are moving towards CPAP for asthma as well, helping keep those airways open and improving gas exchange while you're getting the other medications like your Duonems and whatnot on board. Intubation in the asthmatic patient does not usually have a good outcome, which is unfortunate. So early aggressive management of the airway is good in these hypoventilation patients. And if you can, and again, this is more of a consultation with medical control and the receiving facility. Oftentimes they will get respiratory therapy on board very quickly, and as a result, you can actually have RT at bedside with CPAP, more than likely BiPAP. They're ready for your patient handoff. So the big takeaway from this is there's a whole laundry list of stuff that can cause people to not be breathing. It can be drugs, it can be viruses, it can be a head bleed, it can be any manner of things. For the pre-hospital provider, falling back on your ABCs is very, very important. Making sure that the airway is open, making sure that you've got good gas exchange there, and making sure that they've got a pulse and that they are adequately perfusing. And know that there will be times where you can find a specific cause for their hypoventilation. However, those causes may not always be able to be fixed. As I said, things like obesity, I'm sorry, you're not going to be able to fix the individual who has a BMI of 50 in the back of your ambulance. That's just not something that's... I know, that is a shock to most providers. I don't know. But anyway.
There's no simple pill. I thought maybe just a simple phone call would work.
Chainsaw.
Yeah, that's right. We're going to remove a limb. Well, at least we don't go back to the old days of rotating tourniquets for CHF.
Does the limb removal fix BMI?
It might. Then you've got other trauma stuff to worry about.
Well, I mean, not immediately, but after a while.
Aaron, are there any questions over there or anything?
Not yet, guys. If you guys have any questions for Connor, just go ahead and comment. Like I said, we'll kind of do the same thing we did last time. Give it a few seconds here for anything to pop up and get it answered. So.
And like I said, Jeff will be sending out both of those links here soon. Basically, it's just about 5 or 6 questions on the survey, just to scale about some different things, and then some short answers about what you liked about the presentations, what you feel could have been improved, anything that I lost you on, stuff that you didn't really give a rip about. Some of that stuff is in there too.
Pat and Michelle said you're doing great.
Okay, thank you.
No question, but just a comment.
Okay.
Got any comments or questions yet?
Yes, I'm a little behind. Lagging. I'm lagging.
Just chill for a moment, Connor.
Okay.
We'll see if we have any questions pop in. Alright, as we're waiting for some questions, I'm just going to give you a brief synopsis of what the next, right before, it's almost 11 now. We do have one more presentation to do for you, so take lunch. This is the beauty of doing it this way. If you want to put your tablet, PC, phone, whatever on the dinner table and take it with you, it'd be great. So this next presentation will take nearly an hour, probably two, I believe. So we're going to do the same thing, pause for a few minutes, reset a couple things, get our new presenter in here, get his slides ready, and then we'll go again in about, I'd say 10 or so, maybe 15 minutes. So we'll send out the notification again, so just be watching for that and sign in again in a few minutes.
We got some thank yous and stuff like that.
Okay, great.
You're welcome. Thank you, guys.
Step in here.
Oh.
Yeah, your way.
Oh.
It's all your man.
Okay. Yeah, and if you have any further questions and want to follow up on anything, I believe Jeff has all my contact information, so you can get in touch with me that way. Or some of you probably have my phone number too, so you can. Anyway.
Sure.
Thanks for letting me come in today, and hope to do it again in the future, guys.
Great. Thank you, Connor.
Thank you, sir.
All right, everybody, I'm going to log out. See you in a little bit.
Thank you, Connor.